I know I've seen Katie on numerous occasions playing the piano with her feet or pulling. She's actually one of the few people I know that can peel a banana with her toes. Is that something that she needs to be concerned about, or is there other factors involved?
I think there are other factors involved.
Hello, everybody, and welcome back to another episode of Health Files with Dr. Miles. I am Tanner. I am here with my co-host and researcher, Katie, and of course, the man with the plan, board-certified family physician, Dr. Sean Miles. But today is a very special day, and we have something extra special in store for you, in that we have Dr. Sharrona Williams, board-certified orthopedic surgeon specializing in foot and ankle. Dr. Williams, welcome to the show.
Well, thank you very much.
Glad you could be here.
I'm happy to be here.
Excellent.
So, Dr. Williams, I'm not overly familiar with the orthopedic surgeon realm. Could you familiarize me a little bit with kind of your background and training and what all goes into becoming an orthopedic surgeon that specializes in foot and ankle?
Sure, absolutely. So, of course, undergraduate, right? And then you apply for medical school. I got into medical school at Medical College of Virginia in Richmond, Virginia Commonwealth University. You're there for 4 years, and then after that you apply for a residency. The orthopedic residency is 5 years. I did my orthopedic residency at Atlanta Medical Center. At the time that I got accepted there, it was actually Georgia Baptist, and then I got there and the name changed. But great training. So I was there, and that was 5 years, and then I went to do a fellowship at Duke University for foot and ankle orthopedic surgery. And then I came out and started practicing. And that was 13 years ago.
So obviously you're a physician, you've been through lots of training. There's also the podiatrists that also treat these foot and ankle problems. Can you offer some sort of differentiation between you and the podiatrist, or maybe something that they do more so than you and you do more so than them?
Sure. So a couple things. So I do orthopedics. So I specialize or subspecialize in foot and ankle, but I still treat other musculoskeletal problems. So if you break a bone, I fix it.
So if somebody
at
breaks
any
a
part of your
collarbone,
body, right? I can.
You definitely can handle that,
right? Or your wrist, or
yes.
So orthopedic and any musculoskeletal part of your body, I can treat, whether it's surgical or non-surgical. So if you have fasciitis of your shoulder, some other things. So I went to medical school, and that is a big difference between a podiatrist and myself. Podiatry doctors, they don't go to medical school; they go to podiatric school. They do have a residency out with. And I think I don't think they have to go, but they can specialize in certain areas. For me, I feel like your feet are the base of your body. And so if your feet hurt, everything hurts, right? I mean, people are miserable when their feet hurt. So, but I've got to look at that in relation to the rest of your body and how the rest of your body is involved. And so that sort of is what differentiates me from them, just a little different level of training. And I have a good relationship with lots of podiatrists, and there are great podiatrists out there. A lot of them do a little more forefoot work.
I have a question. Do they ever refer to you?
Absolutely.
What kind of things do you get from them?
So some big reconstructive stuff. So like I said, I know a lot, and we're in the same community. And so I've got their phone numbers, and we talk about cases, and I get referred. So some fusions, ankle replacements, ankle fusions, tibial-talocalcaneal fusions. So these are big surgeries. Triple arthrodesis, which same thing, big surgery, and that can be for a flat foot. But some of the more complex stuff where they just say, I don't do that. Cavus foot reconstructions, or just even second opinions. So it's a very friendly sort of environment where we definitely talk, and I get referred cases.
Now, I know they do a lot of diabetic foot care and toenail things and toenail fungus and things like that. I'm guessing that you don't treat a lot of that on your own.
I typically, that's not my big population. Once again, if you're my patient And a lot of times patients will come in and say, oh, by the way, I have this ingrown toenail, but that's probably something you won't take care of, huh? And I go, of course I will. You're here. Why would I make you go somewhere else for that? No, I'm going to take care of it right now.
Dr. Williams, we're really glad you could be here today. So we see a lot of foot pain in our office in primary care, and a lot of that's heel pain. And I read a stat that about 10% of the U.S. population complains of heel pain every year. So I'm glad you could be here to discuss this pressing matter.
Absolutely. I'm glad to talk about it. So probably more than 50% of the people that I see present with heel pain. There's plantar heel pain, which is probably consistent with plantar fasciitis, and there's posterior heel pain, which may be more associated with the Achilles, but we'll focus on the heel. So typically it is an overuse type of injury or degenerative condition. There are inflammatory components as well, but it's usually overuse wear and tear, and it can be contributed to people who have recently gained weight or that are morbidly obese. People have changed their jobs or activities and they're standing more. People who have either high arches or flat feet. So there are lots of things that can sort of bring on heel pain.
So in my practice, I would say that maybe 8 out of 10 times when people come in with heel pain, it's usually plantar fasciitis. Is that a similar number that maybe you see?
Probably so.
Okay. And for me, when I'm seeing these patients, it's kind of a classic, I've been sedentary, maybe I've been sleeping. First step of the morning is usually the most painful, and it's right at the base of the heel. Is there any other feature of it that patients complain about that you say, hey, I bet this is plantar fasciitis before you even examine them?
So history is critical. So I think it's pretty classic. And the first thing is you listen to the patient and they say, oh my goodness, the first step, I mean, it kills me. And I hobble like an old lady or old man for 5 minutes, and then it feels a little bit better. But the longer I stand, the more it hurts. It's pretty classic if you just listen that it's most likely plantar fasciitis.
Okay.
Are there any other risk factors that can be tied to this plantar fasciitis? I know I wear boots pretty much every day and constantly complain about foot pain, and my wife's always tying it back to the boot. So I need, is that truth? Is there any basis in the footwear or any other factors or symptoms that can contribute to the plantar fasciitis?
Yeah, I think Tanner's from Texas, and I think once you leave the state of Texas, you're forced to wear boots forever. Is that kind of what we see?
It's very true.
Okay. Go ahead, Dr. Williams.
Yes. So shoe wear is absolutely critical. When I talk to my patients, we review what they wear for work, what they wear for their sporting activity, if they're runners or if they're just in the gym, and what they wear around their house. So a lot of folks go barefooted, and I'm not from Georgia, but I feel like I've lived here long enough to say I'm a Georgian, right? But here, a lot of folks go barefooted, which really puts a lot of strain and stress on that plantar fascia. So you've got to review what folks are wearing, and depending on their occupation, how much they're standing and their sporting activity, and shoe wear is critical. So you've got to analyze that and look at their arch and figure out how to better support and offload that plantar fascia. So that's a discussion, and it's a critical discussion that I see is missed a lot of times. And you can make someone better, but if you don't correct some of the mechanical malalignment or improve the support, they go right back to the same problem.
I think there's a whole host of people on TV, different survivor type shows, and people on the internet that talk about, oh, we should not wear shoes. It's so much better for our feet. Back in the caveman days, we didn't have foot problems. What do you say about that?
So I say I've seen more patients with the advent of CrossFit and those little glove shoes.
Glove
who makes
shoes, I like
those?
that.
Shoes with the toes.
Exactly. I've seen more patients using those in the last 3 to 5 years. I mean, there was a surge of foot pain with that.
Oh, really?
So barefoot running is absolutely a bad idea. Someone who has perfect mechanics, which most people are not normal. So abnormal is actually so normal.
So Tanner, don't feel bad for being abnormal.
Right. So, and really normal is defined as slight valgus. So a little bit of pronation is actually normal, right? And so most people will need some support. So barefoot running is a way to really get into trouble.
And since we're on the topic of shoes, maybe you can offer any suggestions on people and how to pick out a good shoe?
Absolutely.
Is there something, if it feels good, it's going to work? Or
Well,
is it,
not necessarily.
Okay.
So that's a great question, actually. So it's very gimmicky. So these shoe companies are very good at marketing, right? And so the whole Skechers memory foam, they're terrible.
Oh, really?
Terrible. But it's memory foam sounds
Sponsored
like,
by Skechers.
sounds like the right thing. Memory foam, right?
Yep.
But there's absolutely no support and it collapses. So it feels good when you put it on and you're like, oh, this feels good. But if you wear it for any prolonged amount of time, if you require any support, it's not going to feel good. So there's some traps out there for the shoe buyers.
You know who's not gimmicky is Justin Boots. They're pretty straightforward in their advertisement. You're pretty much just getting leather. But one of the things that I've kind of tried to add to maybe make them a little bit more comfortable and a little bit more support is these Dr. Scholl's insole support. Is that something that I'm actually doing good in, or does that fall into the memory foam category of gimmicks?
I mean, I think it's better than nothing, right? So I think adding some support is helpful. There's so many insoles out. And it's very confusing for the consumer because when I tell you there are hundreds that are available, right? And Dr. Scholl's is probably the best at marketing.
Yeah.
Right? I mean,
They've been around forever.
They've been around forever. It's like Nike. They've got it figured out. They're branded. So you figure it's got to be good. But they're all levels of orthotics, and they're pretty pricey for what they give you. But it's better than not having them in. So I bet that will help you and make your foot feel better, but it may not be the ideal orthotic choice for you.
Now, Tanner, are you using the ones that you step on the little scale and it spits out a number?
Absolutely. That's actually what I was just going to ask. Is there any credence to the little scale where you step on it and it tells you exactly the type of insole that you need?
So I love that question because that is something I actually review with my patients a lot. So by the time folks see me, they usually have already bought those. Mm-hmm. And they've improved some, but they're like, but it's not, I feel like I need more. And so it could be good for you. The big issue is that when you're on that foot mapping system, it doesn't account for your knees. Mm. And so if you are severely bow-legged, genuvarum,
not to stereotype people from Texas.
Just saying.
But just saying, I just happen to be from Texas, and the first thing that comes up is bow-legged.
But if you are severely bow-legged, then it's going to read out because you're going to strike on your lateral aspect of your foot, and your arch is going to look better than it really is statically. So you're just standing there. It doesn't look that bad, but when you go to push off dynamically, you collapse. It may miss that. So it will underestimate how much support you really need. So once again, it's better than not having the support, but it may not be enough, and now you've paid $50.
I gotta ask, when you ever look at my boots, the heel on the outsides are literally at like a 45-degree angle in where they wear. Is that an indication of what?
You're being bow-legged.
Oh,
from Texas.
And the stereotype is fulfilled.
That's it.
That's it. I'm going to get on my horse and ride on out of here.
So the other part, and since you mentioned that, so if you overcorrect, so this is the part where it's important for someone to look at your complete alignment, because if you get too much support, you may actually walk on the outside further or more, and you can hurt your medial side of your knee. So it's a balancing act, and it's hard to navigate without guidance.
Okay, so that was all really good information. Let's say that I'm a patient and I am having heel pain, probably due to plantar fasciitis. What are some things that I could do on my own before I would come in for treatment?
That's a great question first. Before you seek the help of a physician, I think, and you think you have plantar fasciitis, the first thing I would do is start a stretching program. So it's really about the timing of your stretches. So if you go online, there's hundreds of stretches you can try. But if you start stretching prior to startup activity, that is the most helpful. So anytime that you sit down for more than 15 or 20 minutes, or when you first get out of bed, if you stretch your plantar fascia, and that's just grabbing your toes and extending them, and then you do an Achilles stretch, and maybe a gastroc stretch. And just simple, 3 stretches. To get that start up stretch, it will help you. And if you do that every time, that'd be helpful. Making sure you stay supported, stop walking barefooted. So find a good house shoe, right?
Yeah.
And make sure that you support you as much as you can, or you think you can. And those are probably some of the easiest things. There's a night splint that you could order off the line on Amazon. It's very cheap, but that will passively stop you from, it's not necessary for the stretch, but it's for you to not be plantar flexed at night, because at night you'll just drop into plantar flexion, which will tighten that Achilles and tighten that plantar fascia. So if you do that, that will help decrease that startup pain as well. So those are easy, cheap things to do. Take anti-inflammatories, ice. There's tons of things you can do to kind of help before seeking the help of a physician.
Once you have plantar fasciitis, is it something that you kind of always have and it just comes and goes, or can you completely get rid of it?
So you can treat it and you can solve the problem, but you have to solve all the things that brought you to actually have it. Right?
Okay.
So, and the key is we'll get you better probably 99% of the time. So there's a good success rate of treatment without surgery. But then once you get someone better, you've got to maintain that. And that's when we look at some of the stuff we've talked about previously.
The stretching and things like that.
Shoes and just, I call it good foot health, right? So just like you brush your teeth and you floss and you don't have cavities, right? So we keep you on a good regimen for foot health, depending on how much stress you put. So if you're a runner and you're doing half marathons, you may have a completely different regimen than someone who works at the hospital who's standing on their feet all day.
It's good to know. Say I've been trying these things on my own and it's not really getting better, and I come in to see you. How would you go about diagnosing and treating my heel pain?
Okay, so perfect. So initially you come in and you'll get a set of x-rays. Okay, typically I just need a lateral heel, but sometimes I'll get a full set of x-rays depending if you pronate and looking at your ankle and some other stuff. But so we'll get some x-rays and I'll give you a good exam. Other concerns, so heel pain can present, it can be plantar fasciitis. It could actually be your bone that's involved. It can be posterior tibial tendonitis, which is the tendons around the ankle. It could be subfibular impingement. It could be tarsal tunnel. So there's lots of names, but it's critical that you do a good exam and really see where the pain is focused. And by the time you come see me, you may have compensated some. So you can have metatarsalgia, and you can have burning. So just do a good, thorough exam. Once you truly have plantar fasciitis, and it may be isolated or it may be more, right? But if it's just plantar fasciitis, then depending on how severe you are, so some people come in and it's so severe, they barely can walk. So at that point, a steroid shot is on the table. And that is not a cure. It is just a pain reliever to help you be able to put your foot down. So we would consider a steroid shot. We consider some sort of bracing depending. So there's bracing that could help, particularly if you're a severe pronator. If you're super severe, we may consider even booting you for a short while to take maximal stress off of the plantar fascia, because remember, this is degenerative. So you can have micro tears. And so we really need to rest.
And how long might you boot them like that?
So it depends on the severity and where they show. But if you get a boot, you're getting one minimum 2 weeks, 4 weeks. It really depends on when you show up and if it's other factors. So if you have central heel pain, which we hadn't talked about, but you can have this. I've seen people who come in and have struggled for years with this problem, and they've just compensated and walked on the side of their foot. And so they're hitting the bone. And so it's almost like a stone bruise. And patients will say, when you say stone bruise, a light goes off. And they're like, oh my God, how did you know? And so the bone, if we got an MRI at that time, which we would not do, it would show that there's inflammation of the calcaneus at the heel. Then you get a boot for almost up to 6 weeks. My best analogy is almost like shin splints of the heel. It's the bone is involved, right? So it really depends on how you present on the level of treatment that you require. Once you finish that and you get better, we can start, and your pain is better, and then we can start with some stretching and maybe a therapy. There's dry needling. There's other type of injections that we can also look at. So platelet-rich plasma is an option. There's also amniotic
stem cells and things.
Right. There's all kinds of stuff that pending. So those are sort of last options because they may be more costly. So we always think about trying to conserve money for our patients. But anything's, we will do all that short of surgery.
So if they have dry needling or even the PRP injections, do they need to then stay off of it for a certain amount of time before they start to use their feet again?
Absolutely. So the PRP is basically trying to promote the healing. And so you still have to rest it. And so you're in a boot after that injection. And anywhere from 2 to 4 weeks of rest in that boot before we start stressing you. So.
And now when a lot of people I know, at least for different conditions, when they do the PRP injections, they also will kind of fenestrate the tendon or the plantar fascia with the needle. Is that something you do?
Yes. So that's just microtrauma, causing neovascularization.
Kind of similar to the dry needling, except with maybe a bigger needle?
Yes.
Okay.
So we've pretty much established that I'm more than likely a pronator. I haven't really had a whole lot of troubles with plantar fasciitis, but it sounds like I'm definitely maybe on that way.
You're a good candidate.
Yeah, when you have patients that are coming in and they've been treated or they're maybe on the road to treatment, and we've established that there's a pronator or a misalignment of some sort. Is there anything that you can do to maybe lessen the pronation, or once a pronator, always a pronator?
So that's mechanically how you're built. So it's like your blueprint, right? It's your DNA. So most people, you're a pronator, like you start that way. Now you can worsen. I mean, it can get really flat for you. But once you already do that, you can't correct it without surgical intervention. Now, I do not recommend that because that's a big deal. A flat foot reconstruction is huge. And I have to do that from time to time, but that is not something that you do prophylactically by any means.
I have a lot of patients who have been maybe treated at a podiatrist's office or some other primary care office, and they were told that they had a spur on their calcaneus. And they think, the patients at least, that if it's there, they need to have it removed, and that's going to fix their problems altogether. Can you talk about the calcaneal spur and maybe its correlation with the plantar fasciitis?
Absolutely. So that catchphrase was used many years ago, aka heel spur. And for years, and I mean a long time ago, they would take it out. They would take out the spur. And so it wasn't until we started doing evidence-based medicine and we started looking at anatomic studies when we realized that we were doing far more surgery than we needed to, and it wasn't the problem. Mm-hmm. So the spur itself is not the problem. And when you do a cadaveric study and you look, it's just not there. I probably spend a lot of time convincing patients that spur has nothing to do with it, and let's ignore that x-ray and we can make you better, and that's not the source of the problem. But that name stuck.
Is it ever necessary, like if you're doing surgery, if somebody needs to have surgery for their plantar fasciitis, do you leave the spur there, or?
I do.
Okay.
So I do the surgery when I have to. I don't have to do it often. Most of the time, the people who need surgery have nerve entrapment, and that's their issue. So when I do a partial plantar fascia release, then I go ahead and do a distal tarsal tunnel release, which is where I release anything that could be compressing the lateral plantar nerve or the first branch off the lateral plantar nerve.
So in the surgery, what do you mean by release?
I cut it. But you can't release the entire thing. Well, the issue is when you release the plantar fascia, you will make that arch drop more, which is already usually a problem, right? So you just release the medial third. And then with that, folks can have lateral column pain, which means all the stress goes through the medial and lateral branches of the plantar fascia. And for about a year, they can struggle with lateral column pain. So a lot of this is, a lot of education prior to doing any surgery. Mm-hmm.
So you mentioned tarsal tunnel syndrome. Is that in any way related to the carpal tunnel syndrome that we've heard so much about?
So I use that example a lot when I'm explaining about tarsal tunnel syndrome or distal tarsal tunnel syndrome, because most folks haven't heard of it. So it's not that common. Now, that's all I do is look at feet, right? So I see it more. But it's very similar. So it's a nerve that is being compressed by either a fascia, so just a structure that lies over it, or something that's in that tunnel, whether it's inflammation, whether it's a ganglion cyst or whatever, but there's more pressure and that nerve starts to fire and gets irritated and you get numbness and burning and discomfort. So tarsal tunnel is going to be a little bit higher and just posterior to the posterior tib. So it's going to be at the ankle level. Then the foot's going to be more the distal tarsal tunnel, where we talk about the heel pain. So that's a little bit, now that it's the same nerve just taking a different path and splitting, but it's called something else. But same idea. And the critical part is when you're looking or you're evaluating a patient, usually there's more than one thing going on. So you've got to be careful to make sure that you really check everything. You check the tendons, you check the nerves for any issues, and look and see if there are any signs of compression.
Now, a lot of people for carpal tunnel syndrome will have steroid injections into the wrist that seems to help give them a relief for sometimes months on end. Is that true for tarsal tunnel syndrome also?
So yes, that is one of the treatments that you can do. The other thing is it's a lot of mechanical. So most people who have tarsal tunnel syndrome or distal tarsal tunnel syndrome pronate a lot. So we'll go ahead and put them in a brace called a posteriotibial tendon dysfunction brace that really supports and prohibits the pronation. And they usually see a change in their symptoms, and that's usually a good sign. You also, we can look at nerve conduction EMG studies and look at the nerve and see once you start having changes on some of the studies, then a release is probably where you're headed. So that can be more surgical than the plantar fascia part. Yeah.
So I know that like carpal tunnel syndrome, oftentimes it's associated with like a lot of typing or a lot of repetitive acts. And I know I've seen Katie on numerous occasions playing the piano with her feet or pulling. She's actually one of the few people I know that can peel a banana with her toes. Is that something that she needs to be concerned about, or is there other factors involved?
I think there are other factors involved.
So I've got to ask, in as many feet as you see during the day, can you just look at I know you mentioned the tendons and all of the inner workings, but can you just look at a foot sometimes and be like, that foot's going to have problems?
Absolutely. I do it all the time and I don't mean it. So I maybe just you can't help it. You're at the grocery store and you go, oh man. And I just want to give my card out sometimes. I know if they don't have trouble, they will. And it's like, we should have a discussion about how to keep you out of trouble.
How would you like to be walking down the aisle and an orthopedic surgeon comes up to you and says, here, this is for the way you walk. And you're like, but I don't have any problems. You will. Just give it time. Just hold on to it. Give it time. Now, I know you mentioned that the body you're given is the body you're given, and that's kind of what you're stuck with. But is there anything that you can do, maybe strengthening a muscle or doing a particular exercise that can help maybe lessen the effects or maybe reduce the amount that you pronate or walk, or the mechanics side of it?
The mechanics you're given are absolutely the mechanics that you're given, but there are exercises that can be done, and a lot of times I will send folks to physical therapy, even if not for a stent, at least for an exercise program where they are just instructed and watched and making sure that they're doing it properly, for exercises that can be helpful in strengthening the tendons and muscles around the ankle and keeping your symptoms down. That would not negate the support that you require. I mean, it wouldn't take that away, but it would help. So there are things that can be done.
Speaking of exercise, while we're on that topic, you mentioned that a lot of times the weight that people carry and the obesity factors take into account. How involved do you as an orthopedic surgeon get in that when you know that a lot of the problem may be that the leg's just not meant to hold up that kind of weight? Do you kind of get involved and say, hey, we need to maybe look at dietary restrictions or an exercise program? Or do you kind of leave that more towards the primary care side?
No, I probably get more involved than I should, because I'm just overall, I want to discuss everything that can help you. So I probably spend just a little bit too much time on everything. So we will address obesity, or even if you're just overweight. Most of the time, I start off with, well, let's make your feet feel better so we can get you back to exercise. And once we get there, then we start talking about, okay, now the discussion is what you can do. So the last thing I say going out the room is, okay, no aggressive exercise, no pounding. But guess what you can do? You can get in the pool. I'm okay with that. I'm okay with you on a stationary bike. No, I don't want you walking for exercise right now, but we're going to get back to that. But these are the things you can do now till I see you again. And then each visit, I review what you can do now. So like, okay, so now you can do more than the bike. Now I'm okay with the treadmill, no incline, but, et cetera. So I really review. My goal is to decrease your pain, improve your function, and keep you moving and exercising. So I go over a lot of that.
Is the elliptical, is that considered somewhere in between the bike and the treadmill, or is...
Exactly. You still get to put a fair amount of pounding on that elliptical. So that's not my first, that's in between. So to me, that's more like walking for exercise. So that's not going to be the first thing on my list, but that's going to be, we'll get there. And that's when I'm okay with, you have no pain. We've solved your pain. We've given you or gone over, and you've gotten the shoes and inserts or whatever we thought you needed. And then we are easing back into higher impact exercises.
So you mentioned total ankle replacement. Now, that's something I didn't even think was possible, being it's just such an intricate joint and so many different movements in so many different directions. How does that work, and does it typically have pretty good results? So yeah, the results are actually very good. So I can tell you a little bit of background or history. So just like the knee and the hip, when they first came out, they didn't last very long, and they went through some difficulty, and then went back to the drawing board, and with technology got better implants and continued to work on the surgery and became very successful. So the ankle was out many years ago and wasn't very successful. So they took it away. And fusion was the primary treatment for ankle arthritis. And then once again, with the advent of technology, new implants, with the advent of using CT guided implantation specific for each patient, it became where you could actually put in an ankle and it was reliably placed and via CT. So that has actually been out for at least 12 or so years and just getting better and better. Long-term results are looking good. Studies are out, and in the right patient, it can be very, very successful. And the reason why there's a movement for that is to save the motion in that joint. So when we typically fuse a joint, particularly the ankle joint, in about 10 years or so, the joint below it is going to be arthritic. I mean, it's just a fact. Your body will compensate, and now you have arthritis in the following joint. Now, what are we going to do about that? We'll fuse that joint, and we'll just keep on. And so you basically lose the function, and it becomes harder to have the physiologic function and pain, etc. Right? So there was always this option of looking, how do we stop doing the fusion? How do we reserve motion? And that's when the ankle came back strong, and is doing quite well.
I want to go back and talk a little bit about plantar fasciitis again and steroid injections. And you said that they're really good at helping calm the pain down and allow people to maybe do their exercises and stretches and everything and get on the path to healing. How many is too many? Because sometimes I have patients who come in and they've been to other providers, and they've had multiple steroid injections, maybe one every couple months in the heel like that. And to me, that doesn't sound like it's very good.
Right. So there's always risk with injection, a steroid injection. So there's infection, obviously. There's rupture of the plantar fascia, bleeding, nerve injury. So you want to I typically will just do one. I wouldn't repeat it right away. I would maybe do it within the next 3 months or 4. And I always am upfront with the patient saying, listen, this is not going to heal you. This is just going to make your pain better. The worst thing you can do is leave my office and not do anything else that I say because you feel good. I said, because you'll be right back here and it will hurt the same. And we'll be right back at square one. So I said, this is just to let you do the things to make you better, which means rest, letting it heal, then strengthening, stretching, and so we go over all that. And that works fairly well because and we're not aggressive with the shot. If we can do everything else but the shot, we'll do it. But sometimes if you really can't walk, you need some pain relief. But it is not a solution. It's just to aid you to get to the end. So I don't think multiple shots is a good idea. I wouldn't do it.
So I was talking to my mother, and apparently she has Martin's neurosis. Do you know anything about that?
Close.
That's close. I like it. And so you said it close enough that I can translate it.
Okay,
That's
so
perfect. So Morton's neuroma is probably, I suspect, what she was talking about.
Okay.
So Morton's neuroma is fairly
Is your mom
common.
neurotic? Because it may be that.
It's not her, it's Martin.
Okay.
So it actually can be irritation to your digital nerve, and it can cause you to have pain. And the interesting part about Morton's neuroma is most folks come in and they really can't describe what's wrong. It's so nondescript. I don't know. It feels weird. I don't know. It kind of burn. Well, and they just go on. And then I say, I listen. I go, does it feel like a balled up sock under there, like you're walking on a marble? Yeah, that's exactly it. So it's typically irritation to that nerve, though, and it can be secondary. So it means you can have another problem, and you just started altering your weight-bearing mechanics, causing that irritation, or it could be primary. So a good exam is critical, and then there's tons of treatment for that. 80% of people are treated successfully without surgery.
So how about steroid injections for that? Are those just temporary, or is that going to somehow shrink this neuroma?
So the interesting part is it's not. So when you look it up or look online or you see a picture of this grossly abnormal nerve, well, it's not. When I actually go into surgery, the nerve looks normal most of the time. So it's not a mass. We say, I can feel the neuroma. No, you can't. It's usually the inflammation around that joint causing the irritation. And now if it's long-standing, that nerve can get scar and fibrosis, and it can thicken, but that's after a while. Most of the time you can't see it. Most of the time you can't see it on MRI, but sometimes you can. But it's not like you get this big fat nodule of a nerve. So you're really trying to reverse the irritation around that nerve, right? So the shot is something's going to help the pain. It's going to decrease inflammation. And then you got to do something again about mechanical, right? And so a lot of times there's splints, there are Boudin splints or taping the toes so that when you go to push off and your toes extend and you're pulling that nerve, if you stop that, you stop the irritation of that nerve. You do that for 4 to 6 weeks. So it's more than just the shot. The shot alone never, and not all, but almost every scenario, the shot is not the cure. It is just helping you get to get better.
My mom's going to love that because she actually asked me, do you need to write this down? I was like, no, I'll remember. That's close.
You remembered it perfectly.
It was close enough.
So we talked about a lot of different things that can cause foot and specifically heel pain, such as nerve entrapment, plantar fasciitis, posterior tibial tendonitis, and tarsal tunnel. And it sounds like most of the time it's not surgical, but the most important thing for someone having these kind of pains is to go and be seen and get a good exam to really figure out what's causing the problem. That's
completely true. So I think it's critical that if you have done all your home remedies and things that to address it, just come in, and you'll be surprised that there are really small things in a regimen that we can put you on to help you get better. And rarely does that include surgery. And I'm, orthopedic surgeon, which
you always operate on everybody, right?
And that's the scary thought, right? It's like, I'm not going to the surgeon. I don't want surgery. But, a good portion of my population is non-surgical. And so I and my group with OrthoAtlanta, we believe in exhausting all conservative care. And then if you wind up being surgical, it's because we failed everything else, right? And so then we have to make a decision. And I always tell folks, and this is my first conversation, I think we'll get through this without surgery. But if we go through everything and you're still miserable and we've really truly failed, our conversation is going to have to change. And we're going to have to come up with a new plan, because one thing I know is you can't stay like this. We got to get you functional. So, but I don't have to we just don't have to do surgery that as often as you would think.
Dr. Williams, now you're with OrthoAtlanta here in Newnan. Now, do you primarily work just in this area, or do you service other communities around the area?
Other communities as well. So I'm in Newnan, I'm in Fayetteville, and I'm also in Peachtree City.
And OrthoAtlanta is pretty much most of Atlanta, right?
Correct.
Is there any subsection of Atlanta that OrthoAtlanta doesn't cover?
No, we're everywhere.
Okay. So if someone wanted to find OrthoAtlanta, I guess orthoatlanta.com would be a good place to look on the internet?
Absolutely.
Okay.
Dr. Williams, I cannot thank you enough for coming on the show. I know we all learned a ton as far as just things we just didn't know about orthopedics and the foot and the ankle and just all the little intricacies involved. And I just can't thank you enough for coming onto the show and just educating us and our listeners that tune in.
It was such a pleasure to be here, and I thank you for inviting me.
So we learned a great deal today, but what are the key takeaways that we can take with us as we re-enter the world and go about our daily routines? We found that if you find an orthopedist staring at you or following you through the grocery store, don't make them stop you. Just go ahead and make that appointment on Monday morning, because you've got a hitch in your get-along or something that's obviously concerning. We learned that stereotypes are sometimes in place for a reason, as the guy from Texas apparently walks bow-legged, and the amount of people walking around barefoot in Georgia is staggering. And finally, don't be scared off by the term surgeon. You can always take comfort in the fact that they're going to exhaust every option available before even exploring the idea of surgical intervention. So if you need to say orthopedist or whatever makes you comfortable, just do that.
You have been listening to Health Files with Dr. Miles, and we hope you enjoyed it and were able to learn about achieving and maintaining good health. Subscribe to our show to hear the latest and greatest in the news of medicine and health. Don't forget to rate us and share us with your friends and family. This show was hosted by Tanner and co-hosted and researched by me, Katie, and of course, providing medical expertise, we have Dr. Miles, board-certified family physician. Visit our website, healthfilesradio.com, to learn more about us, our show, and specific resources we used on each topic.
And a special thank you to Dr. Williams of OrthoAtlanta for coming out and just educating us on orthopedics and the various intricacies of the foot and ankle and other orthopedic topics. As always, we are here for education and entertainment. You should take our recommendations not as specific medical advice, but as powerful knowledge to review with your own doctors. And just like every foot is different, you as an individual have your own unique health issues and needs, and they should be treated as such.